Today I'm going to discuss two future trends, and I'm not sure which of them is more worrying. First of all, the future of the Diagnostic and Statistical Manual seems to be at risk or in question. And the second thing is, there are various attempts at legislation to allow state authorities and other authorities, including medical authorities, to detain people based not only on their current mental health conditions, but on some kind of prediction or prognosis. This is beyond terrifying. My name is Sam Vaknin. I'm the author of Malignant Self-Love, Narcissism Revisited. I'm a professor of psychology, so be careful. In the future, I'll be able to detain you, and I won't even need the DSM. Okay, Shoshanim, don't get alarmed, don't panic. Let us delve right in and educate and enlighten ourselves. So there was a public kind of press conference, the American Psychiatry Association, APA, in the annual meeting. They presented exploratory plans for a new edition of the Diagnostic and Statistical Manual of Mental Disorders, also known for short as the DSM. Currently, the DSM is in its 5th edition text revision. The 5th edition was published in 2013. The text revision was published in 2022. The bizarre thing in the press conference or in the annual meeting was that the APA refused to commit themselves to publishing a full 6th version of the DSM, the DSM-6. They were asked by multiple participants and the press, when is the new edition coming out? And they wouldn't say, and they wouldn't commit themselves to a new edition. Instead, they've established a DSM Strategic Committee. The chair is Maria Oquendo, MD, PhD, Head of Psychiatry at the Perelman School of Medicine, University of Pennsylvania, Philadelphia. And so this is beyond bizarre. The strategic committee hasn't been established yet a chairman has been appointed. And what does it mean strategic? It means they're considering to scrap the whole enterprise. Oquendo said that the goal of the committee, the goal of the group is transparency and to solicit public feedback. I'll let her talk for herself. There are people who are DSM fans and some who kind of hate it. So we have made it a point to talk to people and ask how we can fix it, because we are all ears. If there are things we can do better, we definitely want to know, she told Medscape Medical News. At this stage, there are 4 DSM subcommittees. One committee deals with social determinants, the other one quality of life and functioning, biomarkers, and structure. 4. There's been a variety of oral sessions held partly also throughout the meeting, and each subcommittee chair presented preliminary plans. Everyone was very careful to emphasize that this is an early phase or early stage, it's still in development, everything is open to revision, etc., etc. Oquendo again, she said, why now? We want to advance the efforts that were started in the DSM-5 revision process, with the idea that it's time to move the psychiatry nosology forward. Specifically, we want to reflect evolving knowledge. The goal is to make the manual a truly living document with updates occurring in step with scientific advances. And yet she refused to confirm whether this was the groundwork for what eventually would become the DSM-6. And she did say that something is going to be published in about 4 years from now. But she wouldn't commit herself to a DSM-6. Now, the manual, the DSM, has a long history, as some of you may know by now. The first edition was published in 1952, and it was comprised of 100 pages. The current edition, 70 years later, is 1,100 pages. There was a second edition in 68, a third edition in 1980, a very celebrated edition, and the fourth edition in 1994, and there were various text revisions in the middle. And so, what were the big changes in the DSM-5? Honestly, they were mostly cosmetic. Some classifications for several diagnoses were revised. Some diagnoses were put together. Roman numerals were discontinued, and abbreviations introduced, and so on and so forth. And they removed the multi-axial system, axis 1, axis 2, etc. Multi-axial system, first introduced in the DSM-3, was taken out. And initially, the committee of the DSM-5, they said that they're going to shift to dimensional assessments. They're going to move away from bullet lists and criteria, and they're going to move away from what is known as a categorical approach, and they're going to describe mental illnesses and mental health disorders and mental health issues on a spectrum with a kind of dimension in a more literary form that captures the essence of these disorders, including emphasis on trait domains, on functioning, on symptom severity, and so on and so forth. Chapter orders were rearranged, grouping of disorders rearranged, etc., etc. But the truth is that it took a decade to develop the DSM-5, years of planning, field trials, revisions, public feedback, multiple rounds of updates, you name it, a lot of brouhaha, and I'm sorry, but the DSM was stillborn. DSM-5 was stillborn because it copy-pasted the bulk of the text of the DSM-4. True, it introduced the alternative models. There's, for example, an alternative model for personality disorders. Not all of them. For narcissistic personality disorder, borderline, antisocial, and so on. So there is an alternative model, relegated to page 881, by the way. But the diagnostic criteria, the outdated diagnostic criteria of the DSM-4, a 25-year-old document, were copy-pasted verbatim and included in the DSM-5, which is beyond shocking, honestly. In March 2024, the Board of Trustees of the APA approved the creation of the Strategic Committee that I mentioned, with Oquendo as the chair, and so on and so forth. And the task is to monitor new developments that could affect the structure, definition, and criteria of DSM disorders, as if nothing has happened in the past 25 years. Oquendo again says, the rapidity of scientific developments in psychiatry has never been faster. The idea is we want to integrate critical feedback on the DSM and work towards including classifications, models, measurements, and advances in neuroscience. Good luck with that. Oquendo is saying all the right things, but she is echoing sentiments which are at least 15 years old, and nothing has been done owing to commercial pressures by insurance companies, pharmaceutical industries, and so on and so forth. Oquendo says that the APA wants to harmonize with the International Classification of Diseases, the 11th edition of the ICD. The ICD is used by 80% of humanity, and it is like light years more advanced and more updated than the DSM. So synchronizing or harmonizing with the ICD would be an excellent starting point. There's also a new emphasis on neuroscience. The first DSM oral session introduced a kind of subcommittee focused on the importance of functioning and quality of life, and it's actually a euphemism for neuroscience. As noted in the abstract, the goal is to evaluate how these two factors, functioning and quality of life, I'm quoting, can provide valuable insight into the patient's perspective on how their disease impacts their ability to carry out important activities, as well as provide key indicators for treatment progress toward patient-centered recovery goals. The chair of this particular subcommittee is Karen Drexler. She's an MD, Associate Professor, Department of Psychiatry and Behavioral Sciences, Emory University School of Medicine in Atlanta. She told people in the meeting, in the annual meeting, that key aspects, including the perspectives of the individual, family, community, and clinician over time, should be included, she said. They're all valid. The social determinant subcommittee, the other one, has another task. And its task, its assignment is to assess the impact on mental health from factors such as ethno-racial backgrounds, sex and gender, belief systems, personality, income, and individuals' living circumstances, socioeconomic stratum, exposures through the years to advantages and disadvantages, maybe even incorporating the ACE model, Adverse Childhood Experiences model. And both subcommittees are examining single or multiple instruments to determine which are most reliable in assessing these factors. But the emphasis, as you can see, is on medicalizing psychology. All the heads of the subcommittees are medical doctors. They are technically or practically psychiatrists, but they're not psychologists. And so there's an attempt to medicalize psychology by actually converting it into a branch of neuroscience and by emphasizing medications. I will leave it up to you to construct a conspiracy theory around this indisputable fact. For example, maybe the pharmaceutical companies are behind this. Who knows? I'm not saying. Okay. The biomarkers subcommittee is supposed to, as they say, bridge the gap between psychiatry and neuroscience and to evaluate the benefits and potential risks of incorporating a biological approach into the diagnostic process. The group is also exploring the use of wearable devices. There is a general trend away from psychology as we have known it and into neuroscience, biology, neurobiology, neurology, going back full circle to Sigmund Freud, who was a neurologist actually. So now everyone is talking about heredity. Everyone is mentioning genetics, brain abnormalities, genes, medications, and yet the level of knowledge in these fields is very, very low. These fields are pioneering fields, and at this stage there's a lot we don't know about the brain and a lot we don't know about genetics and heredity. And to try to convert psychology into these puerile adolescent sciences, some of them pseudosciences, is really a seriously bad move, in my view. Very hubristic, very arrogant and grandiose. So the DSM is, in my view, straying, going the wrong way, away from coping with the patients as a whole, as a totality, including, of course, genetics and brain, but also life experiences and personal history and ambience and so on, away from this, and with emphasis on neurobiology and brain and devices and medications and so on and so forth. There's a fourth subcommittee, and it is tasked with determining strategies to integrate a dimensional approach into the DSM's foundation using a more organic and functional approach. In other words, what has happened is the original DSM committees in the fourth edition, definitely in the fifth edition, wanted to transition from categorical to dimensional approach. They wanted to transition from bullet lists of diagnostic criteria to a descriptive model that captures the essence of the disorder or the disease. This was undermined, sabotaged, and obstructed virulently and vehemently by the insurance and pharmaceutical industries. So now the new stratagem is to say, okay, we're going to transition to the dimensional approach, but based on medication and based on brain studies, neuroscience. In other words, we're going to transition to the dimensional approach while catering first and foremost to the commercial interests of our sponsors. That is not science, I'm sorry to say. That is seriously egregious behavior. And that is not harmonizing with the ICD. There's no trace of the ICD in this approach. The ICD is published by the World Health Organization and is immune completely to commercial pressures. It is a true blue document which adheres to the latest knowledge and information in the field. The DSM has been deteriorating time and again, starting with the text revision of the 4th edition, the 5th edition, and the text revision of the 5th edition, and now this monstrosity of the DSM-6. The committee chairman, Dost Ungur, is again an MD, a medical doctor, PhD, McLean Hospital of Harvard and Harvard Medical School. He said that in the annual meeting that the current manual has faced criticism for being overly specific and too vague, particularly in cases involving unspecified diagnosis. He said only a minority of patients present with a classic disorder as described in the current DSM. Most present with a mixture of problems to varying degrees along dimensions of mood, anxiety, psychosis, and addiction. That is all true. So why not adopt the approach of the ICD, which is basically trait domains, the combinations of traits, behaviors, and so on? Why not go the ICD's way, which essentially says observe the patient, characterize the patient using a series of Lego bricks, and then come up with a diagnosis that is unique to the patient, tailor-made, customized, idiosyncratic. Why not go that way? Because then insurance companies will protest. Insurance companies like homogeneity and uniformity, and the pharmaceutical companies will be very pissed off, because in the vast majority of cases, medications are not only not necessary, but they're damaging, as recent studies about antidepressants and so on are finding out. And the campaign against psychedelics is an example of the undue influence of the pharmaceutical industries on the profession. Ungur introduced a preliminary and evolving concept involving 4 boxes that clinicians would fill out that would potentially include contextual factors, biological factors, diagnoses, and transdiagnostic features. Ungur emphasized that the current content is only illustrative and not a formal proposal. So it's just to illustrate the way the group is thinking about a workable framework. The next step is to gather data and feedback from the field on what this structure should include. And then step 2 would focus on proposing specific content. After the presentations, people asked Ungur whether there have been detailed considerations of how future updates to the new manual might be handled, including frequency and use of tech-driven platforms, a Wikipedia-style approach maybe. And there was the chair of the session, Nitin Guptai, also medical doctor, chief of research and deputy director of the APA, and he said, no decisions have been made yet. Guptai said, there is such a thing as too many updates, but at the same time as the science advances, we don't want to wait to address that. So we need to find that sweet spot in the balance. No kidding. Okay, what about suicide and suicidal ideation, suicidal conditions? Should they be separated completely from standalone diagnoses? There was a session that explored the possible inclusion of 4 suicide-related conditions as distinct diagnoses in the next edition of the DSM. All of this has been proposed previously, multiple times, by the way. It's regurgitation, big time. And these include suicidal behavior disorder, suicidal behavior within the past 24 months, non-suicidal self-injury disorder, which may precede suicidal behavior, suicide crisis syndrome, a mental state of entrapment and ruminative flooding with or without suicidal ideation, end quote, and acute suicidal affective disturbance, a conscious suicidal intent that escalates rapidly. In the DSM, in the current version of the DSM, the text revision of edition 5, suicidality is included only as a symptom of other conditions, such as depression, borderline personality disorder, and so on. And so here's what the presenters noted, I'm quoting, nevertheless, a recent report estimated that 19.6% of individuals who attempted suicide did so despite not meeting criteria for any existing psychiatric disorders. And they added that new suicide-specific diagnoses would help identify at-risk individuals who would otherwise be deemed healthy by current suicide risk screenings. So there's this debate, and regardless of whether these are included in the next DSM edition, if there is one, or not, Edward Selby, professor of psychology at Rutgers, said this in the presentation. Establishing suicide risk assessment and intervention competency across disciplines will be essential over the next several years. Michael Myers, a medical doctor, chaired the scientific program committee. He's a noted expert actually on suicide prevention. He said that he is all for the inclusion of suicide-related conditions. He said this has been in the works for at least 10 years, more actually, 20. That there is something outside of our conceptualization in DSM and ICD that warrants it as a standalone. Oquendo agreed, but she noted that the DSM is also used for its coding, the insurance companies looming. Yeah. So as much as a group may want a new diagnosis to be included, it's important to understand the potential downstream effects inclusion could cause, she said. In other words, how are we going to get paid? Therapists, psychologists, psychiatrists, especially psychiatrists, how are we going to get paid if there are new diagnoses without an appropriate code to claim the insurance money? It's all about money, it seems. And so starting a brand new DSM manual from scratch isn't realistic, she noted. She said, we need to be pragmatic. We cannot just start over. I have no idea why, by the way. We cannot just start over because that has implications for people who are getting treatment today and whether their insurance is going to cover it. These type of practical considerations are essential. Do you believe this woman? Do you believe what you have just heard? We cannot update the manual. We cannot get it up to speed. We cannot reflect the current knowledge. We are bound to stay behind 2 or 3 decades. We are bound to falsify things, pretend that they don't exist, and a million other issues. All of this because we need to claim insurance money. So there were 9 prominent medical and social care organizations that have jointly condemned the proposed amendments to mental health legislation. So one of the main issues in newly proposed mental health legislation is detention. There's a proposal, series of proposals actually, in multiple locations and multiple jurisdictions and so on, including on the federal level, a proposal to extend police powers of detention to medical practitioners. In England and Wales, this is it's on the verge of becoming law. The amendments in England and Wales were tabled during the passage of the Mental Health Bill. They passed through Parliament, and these amendments would empower authorized individuals, including medical professionals, to detain someone undergoing a mental health crisis. At this stage, only the police have these powers of detention under the Mental Health Act of 1983. So in England and Wales, your psychiatrist could detain you. Your psychiatrist and your psychologist and your therapist and your social worker will acquire police powers. Similar proposals are in a variety of countries, United States, Australia, Israel, other places included. This is a shocking reversal, which provides your caregivers with the power to arrest you, basically, indefinitely. Because this is not the kind of arrest under the criminal code and so on, where there's habeas corpus and you should see a judge. And so this is an indefinite detention. The 9 groups, including the Royal College of Psychiatrists, the Royal College of Nursing, the Association of Ambulance Chief Executives, they warned of the risk of significant harm with dangerous consequences if these proposals were to become law. They issued a joint statement and they focused on proposed changes to the Mental Health Act. Sections 135 and 136 cover detention of people in crisis in public or private settings. These amendments introduced in the House of Lords would authorize doctors, nurses, all mental health practitioners and professionals to arrest you. Powers of detention. Police officers would only need to attend to investigate a crime or if there were an immediate risk to life. Otherwise, the detention is perfectly legal, according to these amendments, would be perfectly legal, and you would find yourself in a cell with no exit date or exit strategy. The signatories of this joint statement, protest statement, said that police role is vital. The organizations warned that removing police involvement in mental health incidents could be unsafe. According to the statement, and I'm quoting, instances of detentions under the Mental Health Act, where there is no risk, are almost non-existent. They noted that the mere presence of uniformed officers can ensure that an otherwise risky situation remains contained and safe. They also noted that police are essential in carrying out many tasks that medical practitioners cannot perform, for example, to check whether it is safe to enter a home. Yes, the new powers will allow doctors, psychiatrists, psychologists, therapists, social workers to simply barge into your home and arrest you with no warrant. This is mind-boggling what's happened. So this new bill is part of the government's manifesto and the commitment to modernize mental health legislation to give patients greater choice, autonomy, and enhanced rights and support. I'm quoting. This is Orwellian speech. This is newspeak, you know. The manifesto says that they're going to give patients, I'm quoting, greater choice, autonomy, and enhanced rights and support. And at the same time, they're allowing people, just people who are not police officers, to arrest you if you're their patient. That's so much for your rights and so on. They said, the government manifesto says, we need to ensure dignity and respect throughout the treatment. So these are shocking and very worrying developments. And they also create an ambience of hypervigilance and suspiciousness and paranoid ideation. They risk this kind of powers risk the therapeutic relationship. If you know that your psychiatrist can arrest you or your psychologist or therapist can arrest you at any minute, you would be reluctant to share with them certain things, many things actually. And then what's the point of therapy at all? Transferring police power to healthcare professionals is very damaging to the therapeutic alliance and the whole relationship, the whole process. It would discourage people from seeking help. So Dr. Lade Smith, president of the Royal College of Psychiatrists, echoed these concerns. She said, it is well known that at times people experiencing a mental health crisis cannot be safely reached and cared for without the assistance of the police. So delegating police power without proper consultation or planning sets a dangerous precedent and is likely to increase risk to patients and compromise the safety of others. So this is where we are at. The DSM openly, the committee of the DSM openly admit that they are under the thumb of insurance companies and pharmaceutical industry and that they are falsifying the DSM to conform to the needs of these industries rather than to reflect the current knowledge in the field. And in multiple jurisdictions, mental health practitioners, clinicians, and professionals would become police officers with powers far exceeding the police and the courts because they could detain you indefinitely based solely on their own assessment. There's no requirement even of a committee of mental health practitioners, let's say minimum 3. No, any single therapist or whatever can do this. What about rogue therapists, rogue psychiatrists, criminal-minded and antisocial psychologists who would then blackmail patients? If you don't give me £1,000 or £100,000, I'm going to detain you indefinitely. What's going on? I have no idea what's going on. The whole field is haywire, berserk. Phew! From pseudoscience to dystopia.